What we expect of our doctors is changing, so it only makes sense that the way we train them is also changing. Joining us now for what that means for one of the top medical schools in Canada, Dr. Sanjeev Sokolingam, Director of Curriculum Renewal with the Medical Psychiatry Alliance and undergraduate medical education faculty lead for that alliance at the University of Toronto, and Dr. Kim Feldman. She is Assistant Professor of Family and Community Medicine at U of T and former undergraduate director for the Department of Family and Community Medicine, also at U of T. We have no time left for our discussion. Your titles are really long. Okay, first of all, welcome, guys, to our program here today. Why is the curriculum, Dr. Feldman, being overhauled?
Well, as you said, the medical system is rapidly changing. What patients want from their physicians is rapidly changing with access to information, their own and, on the internet. And of course, our medical students are changing. So with the millennial medical student, it's quite a different scenario than it used to be. We have a slide that we like to show of a class that normally has 250 students with our Director of Curriculum, Martin Schreiber, as the lecturer, award-winning, multi-award-winning teacher, and there are 37 students present. And it's because
so where's everybody else?
Yeah, well, they're at home watching yesterday's lectures on double speed so that they can save time. And it's not that they're slacking off, they're actually doing sort of clinical shadowing to get earlier clinical experience to help them with career choices, to get more of a patient interaction that the curriculum wasn't providing.
So, Dr. Sokolingam, I don't want to indulge in the usual stereotypes that we have about millennials, but that feels odd to have, barely more than 10% of the class show up to hear lectures from a guy who I guess is probably a superstar in the field. Is that problematic?
I think it's adaptive to our current society. If we think about how we're delivering healthcare, how our patients even come to us, they've looked up things on the internet, they've looked at apps, they're using things to self-manage. We think about YouTube, all these lectures available online and sifting through this explosion of information. It makes total sense. People are, practically bored with iPads in their hands nowadays, that it's absolutely makes sense that we would start to shape how we teach our medical students in a way that really, not just mimics, is authentic to the environment that we live in.
Dr. Feldman, are you confident that if they're playing back yesterday's lecture at double speed, they're taking in the knowledge they need appropriately?
And I'm confident that they are, and the reason that is I think medical students today have a lot more insight into their personal learning style. I'm confident that they're hearing what they need to hear, taking what they need to take from that lecture in a way that they can understand it probably better than if they were just being passively lectured to. Also, they can actually pause it. If they didn't understand something and they want to hear it again and again and again, that's a plus to that sort of scenario.
You confident about it as well?
I am, and I think with that, it's also complementing what happens in the classroom or other learning opportunities, right? So you can often reinforce some of these things and probably get to application of some of these knowledge areas or skill areas that you're hearing about in some of these lectures.
So the students are different, and of course the next question is, okay, is the institution that teaches them changing to accommodate these differences? What's the answer to that?
Well, absolutely. We've had no choice, really, at this point. We've drastically decreased the lecture, so much less of that passive listening, so much more work the night before, for example, flipped classroom idea where you can come in knowing some of the stuff you need to know and actually using the time of a lecture with the content expert to get your questions answered and interact with the material in a more authentic way. Integrate patient voices, which is something that's been done, but not to such a great extent. And that's what the students crave. That's what they went to medical school for.
Is it a bit depressing, though, for the professor to look out at a room that's 75% empty?
Absolutely.
It is.
Which is another reason why it's not benefiting anyone anymore.
Okay, let's read this. This is an excerpt from the Boston Globe. From last fall. Here we go. The curriculum now features more videos created by professors to help students learn, and classroom time is for problem solving in groups, interviewing patients, and thinking through complex situations that might arise in the ward. Schwartzstein, this is Richard Schwartzstein, Harvard professor who helped develop this new curriculum there. He developed his own YouTube videos to describe biological processes students need to learn, which they are expected to watch outside the classroom. The videos are between 5 and 8 minutes, he said, because students' attention spans don't last much longer. Quote, "We are getting a sense from some students anyway that they don't like to read, they prefer videos." I'm trying really not to be an old fuddy-duddy about this, I really am, but how do you not worry that a medical student today can't sit through a 90-minute lecture about something that's probably really important to helping save a life in the future, and patients ought not to be concerned about that?
Well, I think the key is I think you're really getting to the point about lectures and videos, right? And so if you think about most of the ways in which we watch or view things, we watch at our own pace, we're more self-directed, we have greater access to this information. And if we're saying we're relying on those 8 minutes to learn everything we need to know, then I think we do have a problem. But I don't think that's what we're saying. I think what we're saying is we're going to look at these 8 minutes, students are going to decipher what they need to know, but we're going to then bring them into the classroom in small groups, case-based type learning. We're going to apply some of this to actually real virtual patients, right, or patient cases and real patients, right, earlier on. So, if you think about going back, is a 45, 60-minute lecture enough? It's probably not, right, compared to maybe 8 to 10 minutes of the key facts, but then really applying it and digging deeper into what it means in terms of patient care.
Well, let's see how this really happened. I presume at some point students came up to you and said, "Dr. Feldman, we appreciate these 2-hour-long lectures, but that's not how our generation learns, and we're really not interested in. You're going to have to change the way you do things." And your reaction was what?
My reaction is, thank you for telling me, right? Thank you for telling me what you need, because I think everyone has the same goal, which is good patient care.
I totally don't believe you. I totally don't believe you. I totally think your initial reaction was, "Listen, you little snot-nosed kid, I've been at this longer than you, and I am offended beyond belief." And then after you got over the indignation of it, maybe we had that second reaction. Am I getting closer to the truth here?
Yeah, fair enough.
Okay, all right, good. But at the end of the day, you thought, what?
At the end of the day, we thought, you know what, we need to meet the students where they are. Everyone wants the same thing in the end, which is for the students to learn in the best way possible. And if they can articulate what that is, and if they can collaborate with us to develop it, well, thank goodness that we're actually going to probably be much more successful as far as retention of the information that we want them to know. Plus, the other piece is, it's going to be much more competency-based assessment driven. So there'll be
competency-based assessment driven, which
meaning that there'll be a lot more low-stakes exams, a lot more low-stakes testing, but much more often, so that the students are able to get feedback almost constantly, which is, again, what a millennial craves. And we're able to see where their learning gaps are on a much more individual basis than we ever could, in an exam that happens once every few months.
Now, you two are both pretty young, right? You went to med school in Manitoba?
That's right.
What years?
I don't know if I want to disclose that on television.
I'm going to guess that was it in the aughts or was it in the 90s?
It's finished in the 2000s.
It finished in the aughts. Okay. Dr. Feldman, you?
I'm the elderly one at the table. I finished in the 90s.
You finished in the 90s?
I did.
Okay. Well, I got both of you beat. I finished in the early 80s. Okay. The med school experience for you, though, when you went, it wasn't 5 to 8 minute videos, was it? I presume it was a little more old school than that?
It would have been those lectures, which would have been filled probably more so than now, for sure. And I think that reflects how we've transmitted information before, right? Like, if you think 30 years ago, let's go even further back, you had a wise professor at the front imparting his or her knowledge, right, to a class. You'd be in the library taking out books, you have textbooks. We don't have that nowadays. We have access, we have Wikipedia. Our patients are looking at Wikipedia. We have Google. We have all these online resources. Journals are publishing day by day.
Would you go so far as to say it's actually going to be better now than it was when you went to med school?
In terms of
approach to teaching?
Approach to teaching. I think we're adapting to where our students are right now and where the healthcare system's going.
Okay. Was your med school experience somewhat similar?
Yeah, I went to Queen's, which I'm a big fan of, but it was 8 hours a day. You did not miss a lecture, and I'm a very visual learner, and so for me, that wasn't very helpful. I'd spend my 8 hours, and I'd go home and actually then start to learn the material on my own. And if I think I could have saved those 8 hours and done something more productive or had a clinical experience, my goodness, that would have been much, much better.
So this new approach, you think, is preferable to the approach you got. Is that right?
Absolutely.
Huh. Do you know whether all med schools are re-looking at the way they teach?
Yeah, so certainly many med schools around the country have already made large changes, and the ones that haven't are either in the process or are looking at it. It takes a lot of investment, time and energy and money, of course, and I think most med schools are at the point where they're saying, you know what, at this point we have no choice. We have to, move towards, if we want to create doctors that can not only practice right now, but actually have the skills to be able to practice in the future, whatever that will look like. We need to teach them the skills to adapt, the skills to integrate material, the skills to innovate, to lead.
So the approach will change, but what about the actual curriculum? Does that change as well?
The content is the same, I would argue, from, a clinical medical information perspective, but the ways of learning it and integrating it are much more complex because, as you know, patients are becoming much more complex with the aging population. Medicine itself is getting much more complex with genetics and being able to individualize approaches to care. So that sort of changes, of course, that content, but the content itself is all present. It's just we're applying different modalities to how it's taught.
And when you graduate med school, the millennials who eventually graduate med school, whatever, 3, 4, 5, 6, 8 years down the road, initially when they graduate, are they going to be called general practitioners?
They can, when you graduate, you can go into family medicine, you can go into other specialty kind of categories as well.
They, I suppose, can and will specialize, many of them at some point. But what about initially? They're going to be GPs?
So it used to be that you could be a GP. You can no longer be a GP, and that happened actually in the early 90s because they sort of realized that people were defaulting into, everyone did this general internship, and either you went on to specialize in something else or you just by default were a GP. What they realized was over time that wasn't always producing the best physicians. In many cases it was, but that family medicine in itself has a special set of skills, is a specialty in and unto itself, and that you should apply like any other specialty. So what's happened is students are having to choose a little bit earlier because you don't have that same rotating internship year. You choose, and if you decide to apply to family medicine, it's the same as applying to any other specialty. And in general, you can't go back. So you can't sort of decide 5 years down the road that you want it to be something else. So it is a bit more pressure on the students as well.
I'm from Hamilton, and I've been hearing for 40 years that Hamilton, McMaster University Medical School was at the cutting edge of a lot of progressive change in terms of everything, treatment, the way you teach students and so on and so forth. Is U of T caught up to Mac in approach, do you think?
Oh, no, that's a controversial statement. I'll arm wrestle you over that one. McMaster has done some absolutely incredible things. They have been at the forefront of evidence-based medicine, of problem-based learning, of some of the different sort of ways that we're thinking. The changes that U of T is making aren't that similar to McMaster, although we have collaborated with McMaster in discussing our changes in Ottawa and other universities in Toronto and the US. But McMaster was mostly problem-based learning, whereas we're looking more at a case-based learning model, which is a bit more sort of guided, self-directed activity as opposed to the students setting the objectives themselves. There will still be the more lectures, although there'll be different lectures as we discussed, than something like McMaster, and the assessment piece is much more comprehensive at U of T, so there are differences.
Let me ask you about mental health, because we know that the doctors who graduated 25 or 50 years ago got very little training in mental health relative to probably what they needed to know to deal with a population that has increasingly been presenting mental health challenges. How do you intend to ensure that whatever reforms you bring to training the medical students of today and tomorrow, that they're going to have more knowledge on how to deal with these kinds of issues?
Well, I think we've talked about before the Medical Psychiatry Alliance, and one of the innovative things in terms of University of Toronto is that the Medical Psychiatry Alliance is collaborating, and University of Toronto is one of the partners in focusing on undergraduate medical education, looking at all 4 years and how we can enhance mental health training. So what does that look like? Well, that means that earlier exposure to patients with mental health conditions in the context of other physical health care, again, making it more generalizable, not just to people who want to be psychiatrists, but for any healthcare provider, because as you know, mental health is a broad topic and affects many people. And also to look at new ways of teaching mental health. You know, we have a simulation center through the Medical Psychiatry Alliance that we're hoping to integrate in. We're also looking at some of the online learning and trying to enhance that in terms of mental health content. So it's one of those themes that's integrated and woven throughout the first 2 years and in the latter.
So if you're a student, if you're a med student at U of T going forward, are you going to have exposure to patients who are presenting mental health issues?
So I think before in the old curriculum we would. I would say now it would be much more deliberate in terms of weaving it throughout the training. Before we used to have blocks and little bursts of training, and now
more integrated now.
More integrated.
And the value of that would be what?
Well, if you think about in real world, in practice, when students are going to be finishing their residency and practicing, they're going to see individuals who are suffering from mental health in the context of physical health conditions. And it'll be more like what they see in terms of not just one exposure here. And mental health will not just be seen as like a separate silo in the system. It'll be part of everyday medical care.
We did a program, I think we're going back about 8 years now. We did a program dealing with some of these issues with a Dr. Scott Haig, talking about how he really disliked it when patients Googled their symptoms. And let's roll a snippet from that interview, and then we'll come back and talk about how the doctors of the future are going to have to deal with the reality of patients who are pretty hip to what's going on online, okay? Let's roll that, please, Sheldon.
It was about a lady who came to my office who had seen 3 other orthopedic surgeons before she came to see me, and who actually had an appointment with another one the next day. And she had a very common problem with her knee. She had a 3-year-old boy with her, and more or less in the course of it, it came out that she had read an enormous amount about what was wrong with her knee, and she really had no way of screening what the information that she digested or read was, and she really wouldn't let me treat her. She was a self-diagnoser and wanted me to sort of jump on board her bandwagon with what she wanted to treat herself with.
Well, you call her a self-diagnoser on this program, but that's not what you called her in the article. What'd you call her there? A brain?
Oh, brain sucker, yeah, that's
brain
right.
sucker.
That's a medical term.
That's a medical term, a brain sucker. Okay, well, I want to know about the med students of today who are going to be the doctors of tomorrow and how they're being taught to deal with their patients who are increasingly going to be Googling their symptoms and telling the doctor, not asking the doctor, but telling the doctor, here's what I've got and here's what I need.
So as a family physician, that is 90% of my day. And really, occasionally it's helpful. I'm gonna go ahead and say that. It's always helpful in the sense that you're beginning the conversation. You're actually having some sort of collaboration with the patient. They come in, again, with some information. Now, you may have to direct it, and for some patients, it's not that helpful because it increases anxiety. The good thing is that we're able to do, and that we're able to teach our medical students to do, is that if we have an evidence base, we're able to say, you know what, I know that they've listed the 10 tests that you need in order to rule this out. Here's the reason why you don't need the top 9. You know, I think we probably should do this blood test. That makes a lot of sense in this case, and we do want to, you know, rule that out in particular, and this will help us. But, you know, this blood test is actually, it's only about 1% of the population, and they are usually over 90 and male, and you're, you know, a 15-year-old girl, so that's less likely.
So you don't need it.
So I think the evidence-based medicine is extremely helpful in situations like that. It's just helping to guide the patient towards things that are much more likely.
What's your advice on that front?
I would agree. I think I see patients in mental health who also bring in a symptom list as well as a self-diagnosis. And I work in that interface of physical mental health, and so it's quite common. And I would say, again, if we're training our students to be able to communicate, so not only do they have the knowledge and evidence base, but they're able to engage patients in a way and have a dialogue about, okay, so these are your concerns today. These are exactly as Kim was saying, these are the tests that may or may not be the highest yield or highest benefit for this particular condition. I think it's about approach and engagement that we can continue that dialogue, and you know, I think I'm all for it for patients to take control of their self-care.
I wonder whether either of the two of you will fess up to using Google when you diagnose. Yes? No? Do you? Either of you?
Only when my mother asked me.
Okay. How does that go, incidentally? That'd be kind of fun.
It's interesting.
I'll bet it is. I'll bet it is.
Yeah.
Okay, as the province is planning to improve primary care, we're going to expect more and more from our family health specialists. I think that's probably a given. Do you think the curriculum is going to start to address that? What's your view?
Absolutely. I think we're going to have no choice, right? I think we're going to have to be very clear about what the role is for primary care. I think, there's not a family doctor around who wouldn't agree that we do need to integrate more with home care. We do need to integrate more with public health. And I think these are the sorts of things that are being talked about, which will actually be much more beneficial for our patients later on.
You both, I presume, operate in teaching hospitals, right? Okay, so be straight with me here. Not that you haven't been, but do patients mind when med students treat them?
So I would say it depends. So in the new models of care, there are great experiences when patients have had relationships with students, and I mean by relationships, they're seeing them more than once than just one encounter. So a great example in the curriculum reform is in their third year, it's called a longitudinal integrated clerkship, or an LIC. And these are experiences where students are in clinics longitudinally. So every week they have a specific clinic where they're seeing patients, and they take a bit more ownership in terms of managing patients. And in those instances, patients really take advantage of the fact that they have a medical student who's their navigator, who's helping them through the system.
But they've established a rapport
That's right,
at that point.
Exactly. I think the other issue is, I think we have to be mindful of giving our students more exposure to skills, like using things like simulation or other experiences where they can practice, say, techniques or interviewing on, actors or standardized types of patients before they actually go to the real world and start to actually engage with the real world patients. So I think we have a duty to do both in terms of building relationships and also training them before they're actually out into practice.
I presume at some point, Dr. Feldman, you've had a patient say, I don't know, maybe when you were a medical student, or maybe you've seen it to their medical student, excuse me, Sonny, I want to see a real doctor, I'm not interested in you yet. Does that happen?
It certainly happens, and I think for the most part, patients really actually want to contribute to medical education. They're excited to do that, but for sure there are times, if it's an intensely personal issue or something that you've already been through with your primary care doctor and really are anxious, etc. There are situations where you're just like, not today, and you really have to respect that. That's fair. There are times when I go to the doctor myself, and I'm, a medical educator in my soul, and there's an occasional time I'll say, you know what, I just no med student today, if that's all right. I just admitted that on TV.
I was just going to say, you realize that was
just the once or twice.
That was your outside voice saying that. You know that, eh? Okay. Well, that just makes you normal. That's all. There's nothing wrong with that. Doctors who are in the system today, especially if they've been practicing for a long time, how do they react to this new cohort of learners who are coming out of med schools today?
Well, I think it's a challenge at first in terms of being able to adapt. I think we all get stuck in our teaching styles, supervising students in a certain way, and I think one of the investments as part of curriculum change in this reform has been, at the U of T, there's a huge investment in what we call faculty development and trying to teach our teachers how to participate, engage, and supervise their students in this care. So I do think there is definitely going to be resistance, as there is with any change. But I think being aware of that and having programming out there to support our faculty is really key. And again, it's been a huge emphasis in our curriculum change.
Because I presume the big difference between this group of new doctors and ones from the past, in the past, they wanted to be like their superiors, right? They'd have done anything to get the approval of the people who ran the program and so on and so forth. And if you had to do 36-hour shifts, okay, bring it on. I'm going to prove how tough I am. Whereas, again, you don't want to stereotype, but there may be an expectation among the millennials that you actually change the system to suit their needs as opposed to them changing the way they do business to suit the system's needs. How do you deal with all that friction?
Yeah, there are certainly conflicts that arise, especially, with not as much with the senior teachers, because one thing about millennials, they actually really value experience and wisdom. And so, there actually is a really nice sort of mentor-mentee relationship that develops there. It's more sort of the Gen Xers like myself and people a little bit older, like the boomers, where there can be a little bit more of a conflict. And I think it's just a matter of time generally before people realize that it's a certain style, and start to appreciate, the good things. So, oh, well, actually, I can learn a lot about technology from this student, and what's the latest app that's going to help me retrieve, the medical information faster or better, or relate more to my younger patients, even things like that. So I think over time, our more experienced teachers are extremely accepting and welcoming despite some of the differences.
Well, we hope it all works out, because obviously we need doctors and we need you to be great. So good luck to you both.
Thank you.
Thank you.
Dr. Sanjeev Sokolingam, Medical Psychiatry Alliance and the U of T's Faculty of Medicine. Dr. Kim Feldman, Department of Family and Community Medicine, U of T, and Women's College Hospital. My thanks to you both.
Thank you.
Help TVO create a better world through the power of learning. Visit supporttvo.org and make a tax-deductible donation today.